Yes, okay. Please start.
Yes.
So next case is a case of infective scleritis. Then we.
Good evening to all. I am presenting a case of a 54-year-old male who came to us with a complaint of sudden onset of pain, redness, watering since 15 days. He also gave the history of injury by wooden stick and was advised topical antibiotics after consultation to a private local place. He had best corrected visual acuity of 6/6 and 6/9 in right and left eye respectively. So on examination, we can see a diffuse 360-degree deep scleral congestion, and there is a pus point, which is heaped up lesion. So looking at the clinical examination and on fundus, there were evidences of shallow choroidals. We ruled out the evidence of any retained foreign body. On B scan, the patient showed fluid in the subtenon space, although the vitreous cavity was clear. So considering the history and clinical examination, we made the diagnosis of scleritis secondary to infectious cause. We planned the patient for left eye scleral debridement, and we also did the uveitis profile, which contained CBC, TPHA, HIV, HbA-CG, and VDRL. So in debridement, we debrided whole of this area, which had all necrotic tissue, and we debrided the sclera till the time we had seen the uveal show, and the debrided area was left open. So on the post-op debridement 1 day, this smear didn't show any organism. Uveitis profile was within normal limit. So we started the patient empirically on moxifloxacin eye drop one hourly, betadine eye drop for a larger cover 6 times a day, and tablet Indocap SR 75 milligram BD. So these are the photograph of post-op day 1, 2, and 3. Although there was not much healing, but yeah, granulation tissues at the edges were very well seen. So we decided to discharge the patient on the same treatment, and we added the patient with ciprofloxacin 750 milligram BD. So the patient came for follow-up after 7 days. There was no sign of worsening, but yeah, again the edges showed the granulation tissue. While there was no yield in the debridement sample. So we continued with the same treatment and asked the patient to review after 7 days. So now this is the photograph of debridement 15 post debridement 15 days. We can see a new lesion, new pus point, which are consecutive with the previous lesion. So looking at this nature of the pus point, we were little inclined towards the fungal etiology post trauma. So we planned the patient for redebridement and decided to give the patient with empirical subconjunctival amphotericin. So these are the photograph of the area which we debride in the second sitting. We debrided whole of the 360-degree conjunctival in a advanced circumferential fashion, and we debrided till these we could see uveal show. So as we can see here, these are the photograph of day 1 debridement. 360-degree uveal show is there, scleral thinning is there. We started the patient with oral ketoconazole 200 milligram BD, moxifloxacin 1 hourly, and betadine eye drop 6 times was continued. We asked the patient to review after 1 week post debridement 2. We can very well see the healing of the infectious part of the scleritis. Although there was inflammation, this could be maybe due to topical drug toxicity. So as there was no evidence of infective part, so we decided the patient to start on low dose of topical steroid, and ketoconazole oral tablet was continued. So here are the photographs of day 1 post debridement 2 and 4-week post debridement. There is a complete resolution of scleritis and inflammation, although there is a sequelae and uveal show as a part of scleral thinning. So my case is open for discussion. Thank you for your patient listening.
Thank you, Tanvi. Sir, can we have your comments, sir? Sir, you need to unmute yourself, sir. You are still muted, sir.
Now I'm.
Now you are unmuted.
There is a little delay by the host who is not letting people to unmute. So anyway, it's a great case, Tanvi, that you presented. Very happy outcome, I must say that, and congratulate you on that, because it requires a lot of strength of character to go ahead and debride sclera, and you have shown excellent outcome of that. So sometimes we have to be very aggressive in approaching a case where we strongly suspect infective etiology. And particularly, compared to the Western world, I think our share of infective etiology in scleritis cases is at least twice what is seen in the rest of the world, if not more. And, trauma is a great, because normally you would see infectious scleritis following, say, surgery. Whatever cases I have seen have been following, say, extracapsular surgery or following, Trigen surgery, especially in those days when we used to apply mitomycin C. I'm not sure whether they do that these days, but long time back, almost like, 40, 50 years ago, mitomycin C after excision of the tritium was a very standard therapy. Okay. And that was the culprit for some of these infections to set in and necrosis to set in. So, that apart, what I have seen is the trauma, wooden trauma, or with, when they're going into the fields or they're going into the forest for, sometimes collecting grass or some such thing, they get hurt with the any of these, thorn injuries or some such stuff. So that it will let the infectious organism, the fungus particularly, with organic matter, it will be common, it will be suspected. Although in your case, I think you failed to demonstrate the presence of fungus, I would strongly feel that this patient had infectious scleritis due to Aspergillus or one such fungus. And, it was a necrotizing. So sometimes when you see the patient the first time, one, you have to see either in daylight or you see in red-free light, of the slit lamp, to look for the deeper congestion of the sclera, to look for swelling of the sclera. You can do anterior segmental CT if you have these days to exactly know the extent, how deep is the presence. And if you had done that, or possibly a UVM, you might have seen the extension of the fungal scleritis into the eye, because that is what we fear the most. I think long time back, I think more than 40 years ago or around that time, or 35 years ago, we reported a couple of cases of fungal scleritis where the treating ophthalmologist had given a subtenon Kenacort. I mean, hang on, you give subtenon steroids without establishing the diagnosis of scleritis, and of course, there have been papers, people have reported from the Western world use of dexamethasone or subtenon Kenacort for some of these cases, but fortunately, we are smarter here, thinking our patients may be infectious and not non-infectious, because that will hasten the entry of the fungus into the eye. And, the spread of the non-infectious scleritis doesn't go around the eye. The case like your case went around. Okay. So one looks very meticulously for the fungus because it's difficult to locate. You will not find in the necrotic debris that you remove while you are doing debridement. I think you would be seeing if you went ahead and at the edges of the spreading scleritis, if you're taken a biopsy or some such thing, and because it will be found within the scleral lamellae, not find in the debris. So that is how you look for the fungus. And but injury with a wooden stick, I have seen an orbital fungal infection caused by a wooden stick. Actually, the entry wound was so tiny, it was not even visible. And when we did the surgery, we could remove a very long foreign body which had gone right in, and which we discovered on some of the orbital imaging. So one would look for even the orbit. So while you were looking for into the eye, one would look also into the orbit. Sometimes it could be, come as a surprise. You have managed it very well, I would say that. And I think reported a few cases. I don't know, those cases were seen at your institute or were seen in Bhopal, where she did the debridement for great, I think he has shown excellent outcome like your patient. And choice of antifungal, I think you are being very conservative when you use ketoconazole. I don't know whether it was the availability issues, because one would use either itraconazole or voriconazole to be more effective, and for a long period. I think no antifungal therapy should be given less than 3 months, because it's extremely difficult to eradicate, and this avascular structure, the drugs don't reach, and they lie there. And we have seen in those cases of, I think Dr. Dogra reported on our behalf some of those cases of recurrent fungal endophthalmitis, where they respond very well initially, but if you do not follow it through with the long-term therapy, they tend to recur, because it's very difficult to eradicate fungus from their ocular tissues, anywhere they might be. Okay, so I would urge you to treat it longer than what you've done, about 3 months, I would say.
Thank you, sir. Thank you for highlighting how do you differentiate infectious from non-infectious, which at times can be very difficult for someone who is seeing scleritis not very often. So
yes.
And we do get, sir, in this part, because these patients, they are from farmers mostly. They go to jungles, they get these injuries while they are moving around in the cycle and all, and they don't
in the eye. It's absolutely asymptomatic patient. And these guys are very sturdy, they are working the fields. Small little injuries, they don't even mind. It's like that. But you as ophthalmologists have to chase that angle. So bacterial infection, scleritis, following surgical procedures, and post-trauma is mostly the fungal scleritis. I mean, to summarize this patient. Great patient.